Good morning, everyone. I'm Surajit from Guwahati, and the topic I was supposed to talk on is first attack of dizziness resolved by the time I see the patients. What to do? So, this is forward, and pointer, and this is forward. Okay. So, before I go into the slides of it, when I first got this topic, I actually talked to a few people because there was no set protocol for this actually. I don't know. What do you do when the patient in front of you comes with the history that he had an attack of vertigo a few days back, but he doesn't have it now, and that was a single episode? Do you go for a whole lot of investigation? Do you ask him to go back and come back when he has a second episode? What? So I talked to a lot of people, and everybody came up with different versions. So what I plan to do in this talk is try to finish this talk early, maybe in 10-12 minutes, and then keep a big time for discussions. So I'll try to do that. So first attack of dizziness. Now the first question that comes to us is this: why do I need to do anything? This patient has come to me, had one attack, just one attack, and nothing else. And now absolutely okay. So why do I need to do anything? Why I need to do anything, according to me, stems from the very fact that this person has come to me. He has come to me looking for something. He also realizes his attack is gone, but he is here. So he is looking for something. What he is looking for? What this person is looking for is answers. Answers for what? He's looking for answers for his anxiety and apprehensions. What are the anxieties? Now, when a person, if like most of us are treating vertigos, but many of us have actually not experienced vertigos ourselves. One who has, the first attack is always very harrowing, not only physically, but psychologically. Because here is a person who is otherwise absolutely okay, nothing wrong, and suddenly पैरों के नीचे से जमीन खिसक गई, he is having rotatory vertigo or whatever, and he doesn't know what is happening, how it is happening, what. So this anxiousness, this wanting to know, why did this happen? How did this happen? Why am I suffering? What is happening to me is very dangerous. And the apprehension that whether this is going to repeat. I actually remember a patient who had a single attack, had come to me around a month after that, and he had his wife with him, and this person, after that single attack, had stopped doing all his daily work. And when I talked to him, he said, there are a lot of, what if this happened, that happened, and deep down his real fear was, doctor, every morning I take my bike, my 2 kids to school, and what happens if I have an attack while driving my kids to school and something happens to them? So this whole fear psychosis. I have had patients with attacks, and I ask them questions like, okay, how many social functions have you missed because of a vertigo attack? And answer is 0. And then I ask, how many social functions have you missed because of the fear of a vertigo attack? And they're in tens and hundreds maybe. So this fear and anxiety is what brings this patient of a single vertigo attack with nothing now, absolutely physically Helen Hardy, to us. So what is our job in this? Our job is, number one, to identify the cause that caused that vertigo attack. Our job is not to treat this patient because at present the patient has now no problem. Our job is first to identify the cause, find out if there's any long-term implications of that cause, and then manage. And I'll come into later, there's always a difference between managing a patient and treating a patient. So how do you do that? Of course, there's a dictum. The most important thing in diagnosing a vertigo is history. So we need to have a proper history, a proper clinical examination of these patients, do the required vestibular test, other investigation, proper management, and if need be, refer the patient to some place else. So what do we do in history? Now, we have all been told how history is the most important thing in vertigo management. But taking a history in these patients, a patient who has had a single episode of vertigo, is not very easy. Why? A person who has been suffering from vertigo for a long, he has 6 episodes to fall back upon, he has 10 episodes to fall back upon, he has certain knowledge of his vertigo by now. He knows what triggers it. He knows how he had it. What was the style of vertigo. But a single attack, that person may actually not be able to describe it. This is something like I ask you to describe, say, Shah Rukh Khan. And all of you will come with a big essay on him. And I ask you to describe the cab driver that dropped you from the airport to Hotel Daspala yesterday or day before. And you will have difficulty. You will not even remember whether he has a mustache or not. That first attack of vertigo instills so much, during the attack, so much fear in most of this patient, that when I ask them, was it rotatory, ghar ghum raha tha, ye ho raha tha, sir, chakkar aa raha tha. The answer is, sir, chakkar aa raha tha. No. Did you have blackouts? Haan, aankh band kar liya tha, sir. So, it's very difficult to dig deep and get the history. So, every point is important. When, where, how. Types of dizziness. Because he may come with the word vertigo, but this may not be vertigo. We have the 4 classical types of dizziness. This may be a vertigo. This may be a blackout. This may be a unbalancedness. This may be a mixture of everything. Duration in symptom is very important. It may be a split second to days. There may be associate symptoms, maybe the classical associations of tinnitus, deafness, oral fullness, headaches, and there may be other unclassical. Anything and everything can be associated because there is no set, because we do not know, he does not know, nobody knows what triggered it. So, finally, we have to try and localize those triggers. Clinical examination becomes very relevant, especially hearing, the clinical vestibular test, the positioning test. The systemic examination will especially lay stress on the CVS and the CNS system. So this becomes very important. Now, what are the vestibular examinations we want to do? Here, I think that concept of something like a vestibular mapping or a vestibulogram comes into play. Because this is one patient where even the history may not give us a proper path, a proper road, direction to where we want to go or where our final goal is. Because, again, as I said, it's the difference between describing that cab driver and Shah Rukh Khan. So, here we have to think of mapping the whole balance system. So, we may need to go for a lot of vestibular tests, the VNGs, the VHs, the VAMs, and many more. I think this is where the whole Balance Eye platform is very useful because it brings in a lot of things. So, apart from the vestibular test, we have other tests. Hematological. Hematological is very important. Something as simple as a low hemoglobin can be the factor because here is a cause of dizziness. In my part of the country, Northeast, low thyroid level is so rampant. I am hypothyroid. Almost, now there's a joke going on that we have this citizenship registration going on in Assam. So, anybody who has hypothyroidism and allergic problem, they do not need documents to be proved as me's. That's how rampant hypothyroidism is in my part of the country. So that's the thing. Cardiac causes, ECG, echocardio, maybe even a Holter if you need to. Radiological examination, I'm not going to talk. There's a big discussion coming up. But one particular very important investigation I want to talk about is X-ray cervical spine. I don't think it's necessary. Cervicogenic vertigo is the final diagnosis of me telling I do not know anything about this disease. That's what my opinion. Again, I may be wrong. So now we come to the management part of it. 10 minutes already gone. I wanted to save 10 minutes for the talk. So for the management part here, I have divided into this 4 categories. Why? Because as already mentioned, this patient at present do not need treatment for his disease. He needs treatment for his concerns first. So the first thing he needs is a proper empathic listening and properly telling him what is his conditions, what he can expect from it, and what he needs to do. So, explaining the cause of the vertigo becomes very important, because at the very onset, this patient came to me actually not because of the vertigo, but the fear that was instilled in him by this vertigo. So empathic listening, empathic telling him of the whole condition is very important. So in this category of patients especially, and it's actually true for all vertigo patients, but in this category of patients, sitting down with them for a few hours, discussing the whole thing becomes very, very important, much more important than any medicines that we are giving, any other treatments that are giving. In these patients, we sometimes do give specialized vestibular rehabilitation depending on what's causing it. Because again, if there is no vertigo as such now, why give a lot of drugs? Yes, if we find that that vertigo was triggered by something, electrolyte imbalance, give the required electrolytes. It was caused by first attack of Meniere's, give him beta-histine or a diuretic, whatever is your preference. But the first treatment should not be medicine. He comes to me with one history of dizziness or vertigo 15 days back. My prescription starts writing. That should not be the idea. And finally, if I am able to diagnose this as something non-ENT, or I'm not able to get to the root of this cause, I think referring this patient becomes very important. So it may be referred to anyone. It may be a general physician, a cardiologist, a endocrine guy, a neurologist, or even to a psychologist or a psychiatrist. Referring these patients to these people becomes very important. So a patient who has had a single attack of vertigo, nothing now, coming to me, needs a different or maybe a normal protocol with a different angle. So to conclude, I would say this is a journey for these patients where the patient's fear of the unknown should be the driving force. That should be the reason why we go forward, because he has come with that primary problem. The primary symptom was actually not the vertigo, but the fear. Proper diagnosis and true management, not only treating him with 2-3 drugs, must be the road that is traveled in this journey, with complete understanding of the disease and managing it being the final goal. So that basically is all I want to say about this topic. We still have 7 or 8 minutes, so let's discuss more about it. That's what I want to do.
Well, I agree with your presentation. This is a common unwanted situation when the patient visits with the recent single or first attack of vertigo. So what should be done? In fact, should not do anything. In fact, that's the first dictum. Second practice, what I do, I just hand over the printed form mentioning different history points. This is the standard practice right from the time of Victor Goodhill. If the patient is not intelligent enough to understand or read, then I usually ask the general practitioner nearby and request him that when the patient comes with the second attack, he should try to understand the writings of the form and try to extract the history and note it down. So this is going to help when the patient comes with the second attack. So in between, nothing to be done. No.
In the first attack, nothing. You say reassure the patient and send him back, sir.
Patient is coming between first and second anticipatory attack. All right. So nothing to be done. No prescription. That will go illogical, unethical, and injurious.
Okay, sir. Thank you, sir. So everybody agrees with that? First attack of vertigo, we don't do anything? No. Sir, please, sir.
I think I missed the major part of his presentation, but having a strategy or a protocol for dizzy patients is mandatory for successful practice. But just I have few tips or hints to share with you. For example, if I have history is almost the most important factors in the assessment of this patient. And I heard some words from him that he talked about triggering or spontaneous or duration of the attacks. So for me, if the history, for example, suggests a BBV case, so, and on examination, there was no nystagmus, dexholbaic, McClure-Bagnini test is negative, no nystagmus, nothing. So the history is suggestive of BBV. So I do counseling, and I fully agree with him regarding the importance of counseling your patient. That's important. So I ask the patient to come during the activity of vertigo, and I give them access to my clinic at any time. They can just come to be examined, and I give them a short note that what I want to look for. So I write, for example, it's query BBV for examination during the activity of vertigo. Because in paroxysmal disorders like the BBV, sometimes really you cannot catch the finding. And one of the clinical tips, especially for BBV, ask the patient to come in the morning, because this autoconia precipitate overnight. So the ideal time to get a robust examination finding is to ask your patient to come in the morning.